Welcome to our channel Medicine A to Z. Today we are going to discuss MCQs in hypersensitivity pneumonitis. Which of the following symptoms is characteristic of non-fibrotic hypersensitivity pneumonitis? A. Hemoptysis. B. Chest pain. C. Fever. D. Cyanosis. Answer: C. Fever. Non-fibrotic hypersensitivity pneumonitis typically presents with acute or subacute symptoms, including fever, cough, dyspnea, and malaise. Which radiological finding is commonly observed in non-fibrotic hypersensitivity pneumonitis? A. Honeycombing. B. Ground glass opacities. C. Traction bronchiectasis. D. Pleural effusion. Answer: B. Ground glass opacities. HRCT findings in non-fibrotic hypersensitivity pneumonitis often include ground glass opacities, centrilobular nodules, and a mosaic attenuation pattern due to air trapping. Honeycombing and traction bronchiectasis are common in fibrotic hypersensitive pneumonitis. Which prognosis statement is true regarding non-fibrotic hypersensitivity pneumonitis? A. It has a worse prognosis compared to fibrotic hypersensitivity pneumonitis. B. It has a better prognosis compared to fibrotic hypersensitivity pneumonitis. C. Prognosis is similar regardless of fibrotic status. D. Prognosis cannot be determined based on fibrotic status. Answer: B. It has a better prognosis compared to fibrotic hypersensitivity pneumonitis. Non-fibrotic hypersensitivity pneumonitis generally has a better prognosis compared to fibrotic hypersensitivity pneumonitis. What is the significance of the 3-density pattern in hypersensitivity pneumonitis? A. It indicates severe fibrotic changes in the lungs. B. It suggests air trapping and decreased lung vascularity. C. It is a specific radiological sign highly suggestive of hypersensitivity pneumonitis. D. It signifies the presence of pleural effusion and consolidation. Answer: C. 3-density pattern, characterized by ground glass opacities, decreased attenuation and vascularity, and normal lung, is a specific radiological sign highly suggestive of hypersensitivity pneumonitis. What is the role of cigarette smoking in the development of hypersensitivity pneumonitis? A. Increases the risk of HP. B. Decreases the risk of HP. C. Does not affect the risk of HP. D. Increases the severity of HP. Answer: B. Decreases the risk of HP. Cigarette smoking is associated with a decreased risk of developing hypersensitivity pneumonitis. What is the immunopathogenesis of hypersensitivity pneumonitis primarily mediated by? A. CD4 plus T helper lymphocytes. B. CD8 plus T lymphocytes. C. Neutrophils. D. Antigen-antibody complex formation. Answer: D. Antigen-antibody complex formation. In HP, antigen-antibody complex formation is the primary mechanism leading to lung inflammation. What is the key management strategy for preventing hypersensitivity pneumonitis? A. Antiviral therapy. B. Avoidance of exposure to inciting antigens. C. Supplemental oxygen therapy. D. Bronchodilator therapy. Answer: B. Avoidance of exposure to inciting antigens. The key management strategy for hypersensitivity pneumonitis is avoidance of exposure to inciting antigens. What is the key diagnostic imaging finding in hypersensitivity pneumonitis? A. Pleural effusion. B. Ground glass opacities. C. Cavitary lesions. D. Pulmonary nodules. Answer: B. Ground glass opacities. Ground glass opacities are a characteristic finding on chest imaging in hypersensitivity pneumonitis, along with centrilobular nodules and mosaic attenuation. What is the primary treatment approach for hypersensitivity pneumonitis? A. Bronchodilator therapy. B. Antifungal medication. C. Avoidance of inciting antigens. D. Steroid injections. Answer: C. Avoidance of inciting antigens. The mainstay of treatment for hypersensitivity pneumonitis is avoidance of exposure to the triggering antigens, which can prevent disease progression and exacerbations. Which antifibrotic agent may be considered for patients with chronic HP and progressive fibrosis? A. Prednisone. B. Cyclophosphamide. C. Nintedanib. D. Methotrexate. Answer: C. Nintedanib. Nintedanib may be considered for patients with chronic HP and progressive fibrosis, as it has been found to improve disease progression in this population. What is the primary outcome observed in patients with chronic HP treated with mycophenolate mofetil, MMF, or AZA? A. Improvement in FEV1. B. Reduction in DLCO. C. Decrease in prednisone dose. D. Increase in FVC. Answer: C. Decrease in prednisone dose. In patients with chronic HP treated with MMF or AZA, the primary outcome observed is a decrease in prednisone dose, typically seen 6 months after initiation of treatment. Which of the following immunosuppressive agents has been used in patients with chronic hypersensitivity pneumonitis, HP, who have not responded to antigen removal and systemic glucocorticoid use? A. Cyclosporine. B. Tacrolimus. C. Azathioprine, AZA. D. Methotrexate. Answer: C. Azathioprine. Azathioprine has been used in patients with chronic HP who have not responded to antigen removal and systemic glucocorticoid use, according to observational data. Which of the following statements regarding glucocorticoid treatment for chronic hypersensitivity pneumonitis, HP, is true? Glucocorticoids are always recommended for patients with chronic HP, regardless of the presence of inflammatory features. B. Patients without inflammatory features are more likely to experience improvement with glucocorticoid therapy. C. Glucocorticoid treatment should be rapidly tapered and discontinued after a 3-month trial in patients without inflammatory features. D. Long-term glucocorticoid treatment is not associated with any adverse effects. Glucocorticoid treatment should be rapidly tapered and discontinued after a 3-month trial in patients without inflammatory features. Patients without inflammatory features are less likely to improve with glucocorticoids. Therefore, a reasonable approach is to give glucocorticoids as a trial for 3 months, but rapidly taper and discontinue them in the absence of clear benefit. Which histopathologic pattern is not associated with a good prognosis in chronic hypersensitivity pneumonitis, HP? A. Fibrotic nonspecific interstitial pneumonitis, NSIP. B. Bronchiolocentric fibrosis. C. Usual interstitial pneumonitis, UIP. D. Cellular NSIP. Answer: D. Cellular NSIP. In chronic HP, histopathologic patterns such as fibrotic nonspecific interstitial pneumonitis, NSIP, bronchiolocentric fibrosis, and usual interstitial pneumonitis, UIP, are associated with a poor prognosis compared to patterns like cellular NSIP and parabronchiolar inflammation, with poorly formed granulomas, PIPFG. Specifically, the presence of UIP pattern is linked with a poorer prognosis and shorter transplant-free survival. What is the key difference in exposure between hypersensitivity pneumonitis, HP, and organic dust toxic syndrome, ODTS, in farmers? A. HP is associated with intense exposure occurring on a single day, while ODTS is associated with high exposure on most days for prolonged periods. B. HP is associated with high exposure on most days for prolonged periods, while ODTS is associated with intense exposure occurring on a single day. C. HP is caused by exposure to organic dust, while ODTS is caused by exposure to microbial antigens. ED. HP is a non-immunologic reaction, while ODTS is an immunologic reaction. Answer: B. HP is associated with high exposure on most days for prolonged periods, while ODTS is associated with intense exposure occurring on a single day. The key difference between HP and ODTS in farmers is the pattern of exposure. HP is associated with high exposure to antigens on most days for prolonged periods, typically due to continual exposure to hay or dust containing microbial antigens such as Saccharopolyspora rectivirgula. In contrast, ODTS occurs due to intense exposure to organic dusts, usually mold dusts, on a single day. This distinction helps differentiate between the two conditions in clinical practice. Which of the following statements about genetic predisposition to hypersensitivity pneumonitis, HP, is true? A. All individuals exposed to antigens associated with HP develop the condition due to a genetic predisposition. B. genetic predisposition to HP has only been observed in individuals with familial clustering of the disease. C. The presence of specific MHC class T alleles has been associated with a reduced risk of developing HP. D. The MUCMFB RS3GC 595 minor alleles have been associated with a decreased risk of chronic HP. Answer: D. The MUC5B RS3570590. Minor alleles have been associated with a decreased risk of chronic HP. Studies have identified genetic predispositions to hypersensitivity pneumonitis, HP, suggesting varying susceptibility among exposed individuals. Specifically, an association has been found between the MUC5B RS3570590 minor alleles and a decreased risk of chronic HP. This variant is linked to increased expression of MUC5B, a gene encoding a mucin protein involved in lung defense mechanisms. Other genetic factors, such as specific MHC class II alleles and rare, protein-altering variants in telomere-related genes, have also been implicated in the risk and prognosis of HP. Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.